Welcome, everyone. We'll be starting in just a moment or two once people get signed in. Thank you to everyone who's just joining us. We'll be starting in just a moment.
Good morning. Good morning, good afternoon, good evening. Greetings from Singapore. My name is Alice Chu, a 2019 Berkeley of Masters of Public Health graduate and one of 18 Board of Directors volunteers on the UC Berkeley's Public Health Alumni Association, and I will be your moderator for the event. And we welcome you to our first international webinar ever set up by the Professional Development Committee of the Alumni Association. Now, the Alumni Association has been around for 67 years, supporting the vision and mission of the School of Public Health and strengthening the professional and personal relationships with alums, undergraduates, and graduate students. Now, in considering the vision of the school, which is healthy people locally and globally, the Professional Development Committee wanted to educate our Berkeley community and the public on international efforts in the public health realm. And we felt that there is no better topic than reflecting on the COVID-19 experiences in Asia Pacific. Singapore, New Zealand, and Vietnam currently have 0 to single-digit infections per day. And interestingly, the Global Health Security Index, which ranks 195 countries based on readiness for tackling infectious disease outbreaks, ranked the United States as #1, whereas Singapore was 24th, New Zealand was 35th, and Vietnam was 50th. So we have these 3 outstanding public health experts today who will provide a description of what national and health system policies that were enacted and their perspectives into what worked and what could have been improved. Now, you could type your questions into the Q&A box at the bottom of your screen, not the chat box. The Q&A will be after the 3rd presentation. There is a recording. We are recording, and this webinar will be available. You can contact Eileen Pearl. Okay, the order of presentations will be based on the 2019 GDP per capita. And I'd like to thank the panelists for reminding me that Singapore had a higher GDP per capita in 2019 than the US by $100 at 65,200, followed by New Zealand at $42,000 and Vietnam at $2,700. The first speaker for today is Professor Jeremy Lim, who is the director of the Leadership Institute for Global Health Transformation at the National University of Singapore Swee Hock School of Public Health. He is a well-known columnist for the national newspaper called The Straits Times, and he writes about health policy issues in Singapore. Jeremy also wears many different hats. He's the founder of the Asian Microbiome Library, which is Southeast Asia's first and only precision gut microbiome company. And he's developing innovations and therapies for that. He's an advisor to several social enterprises and innovation firms. He's the former head of Oliver Wyman's healthcare practice, a former hospital executive, and policymaker for Singapore's Ministry of Health. Jeremy is a surgeon by training, and he received his Master's of Public Health from Johns Hopkins. Professor Jeremy, the Zoom platform is yours.
Thank you, Alice, and a very good day to everyone. If you don't mind, let me share my screen. Right. and really delighted to be with all of you as fellow public health students. And I use the term student very deliberately because we are all learning and we will continue to learn. I think COVID has really taken us um, by a lot of surprise. And as Alice pointed out, that really rankings are only as good as your last performance. And here in Singapore, our Prime Minister has well warned us that COVID is really just a warm up, and the country needs to be prepared for disease X, whatever disease X is. So uh, I've been asked to share a few slides for about 5 minutes. So let me be very brief. Let me also assume that most of you have not been to Singapore. So I'll just give a very quick update. Singapore is a tiny country. You could walk from one end of the country to the other end in under one day. We're also very densely populated, about 20,000 residents per really square mile, and this compares to New York City, which is the US most densely populated city, that's at about 27,000. Of course, you can leave New York, but there's not many places to go within Singapore if we are on lockdown or if borders have well closed. So you can enjoy cabin fever within a very small country. And as you can see from some of these photos, that Singapore is very built up. 90% of the population live in high-rise buildings. What is probably three characteristics that have been relevant as it pertains to this COVID-19 pandemic is firstly that we've been governed by the same political party since independence in 1965. So a reasonably high level of trust in the government in terms of both competence and in both of motivation and the integrity and wanting to do what is right for the average citizen. Really, secondly, Singapore has, like many other cities and countries, tried to position itself as a smart nation and as a digital hub. So really internet connectivity, the technological sophistication is really up there with most other countries. And well, e-commerce, we've got the local versions of Amazon Prime, Deliveroo, Uber Foods, and so on and so forth. So actually shutting down the really city is exquisitely painful, but life still can go on. And probably what is relevant is that Singapore, similar to Vietnam, similar to Hong Kong, we were affected by the SARS outbreak in 2003. And this led to a number of measures that I'm happy to speak about during the really Q&A that probably was very helpful in preparing us for what happened in really starting from January this year. So I just wanted to share this slide. And this is where we are in terms of the really pandemic. I must applaud the health ministry. I'm not always the health ministry's biggest fan, but in terms of COVID-19 transparency, in terms of sharing data, it's been quite remarkable that the government has taken great pains to share the data and right down to the granularity. This is where we are today, really November 19, and we've got 4 cases that are imported. We don't have any cases in the dormitories and nothing out in the community. And I think what is pertinent to note out of this slide, if I can just move the cursor, is that the virus started out of China, right? And it was also very close to the Chinese or to the Lunar New Year. And that's also the time when a lot of mainland Chinese travel, and there are 3 favorite places to travel to outside China: Thailand, Hong Kong, and Singapore. So it's really no surprise that the first couple of cases were all the imported cases. This then led to some community spread. And what then happened was that Singapore has a large migrant worker population, and about 350,000 of them live inside dormitories. And I will confess upfront that the dormitories were a blind spot, not in the sense that the government and the population did not recognize that they were at high risk. But I think that the blind spot was just how ill-prepared dormitory operators and the workers were to basically respond. And so when the cases came in from from really overseas, spread into the community, and very quickly spread like wildfire inside dormitories. And what is pertinent is that it took a bloody long time to settle dormitories, because they live in almost slightly lower version than university dormitories, typically 10 to 20 people sharing a room, about 150, 200 people sharing communal kitchens, bathrooms, and so the ability to well safe distance within the dormitories is very, very challenging. So it took a really long time to get everyone settled down. And I think what is pertinent probably in the context of the US is that Singapore had its circuit breaker, which is a euphemism for lockdown. And the decision to lock down was made very, very early when the cases still looked relatively modest. And in fact, there were some public concerns. Why are we locking down? The numbers seem eminently manageable. But I think that the experience is that pandemics spread, when they spread, they do spread like really wildfire. And these peaks that you see are really testament that the circuit breaker was the right thing to do, to essentially slow down the transmission, and also buy some breathing space to allow for healthcare facilities to then be ramped up. Right now, the situation seems to be more under control. We do realize that there are waves occurring around the world, so eternal vigilance is the price of peace. I've put this slide up simply to illustrate that really Singapore's economy is driven by porosity. We live and die by trade and by tourism and by basically connectivity. So the world locking down, globalization going into reverse mode is very, very bad for us, and we have to reopen. So unlike many other countries and really cities, Singapore does not have a choice. Once the COVID numbers are under control, we have to open, and we have announced travel bubbles with Hong Kong. We have unilaterally opened up borders to New Zealand, to Brunei, and to a number of other countries. And we have also restarted cruising, because the cruise industry is actually large here in Singapore, and with adequate safeguards. And now we as public health professionals are watching the space very, very closely to make sure that any outbreaks can be contained very, very quickly. But we do appreciate that we cannot keep the economy shut forever and really ever. We are much too reliant on open borders. So the last slide that I'll share here is the broad approach. And this nice little picture here was taken very early on, when the science was not that clear around wearing of mask. And so the public health non-pharmacological intervention was really around what is today described as safe distancing. So you see all these little markers to ensure that people keep the prescribed distance apart from each other. So what is this really strategy now? It is really balancing. We want to have lives and livelihoods. And what is the right balance? And I guess given that 2020 has been such a horrific year for almost everyone, but it's been very good training. And so if you think of a really step ladder of really public health measures in terms of social distancing, in terms of closing of various facilities, really Singapore now has the opportunity to almost ratchet up and down depending on the COVID numbers, depending on testing and contact tracing capabilities, and lastly, depending on the state of the economy. What's been really helpful is that we have also been able to increase the healthcare carrying capacity, and we have figured out how to house the mild cases in hotels and in temporarily converted facilities, so that we can protect the hospitals, protect the critical care facilities. And of course, the science is evolving. There's promising news about a vaccine, but there's also rather pessimistic news about just how long immunity lasts. And so we just have to keep watching the space, and the strategies, the management approaches, they will change as new knowledge emerges. And on this note, thank you very much. And Alice, can I hand the time back to you?
Thank you, Prof. Jeremy. Thank you very much. And very good presentation. And just the first thing that you said was about the trust of people in the government and the transparency that has arisen. And it would be great, maybe if someone has a Q&A about it, about how trust in governments has influenced the COVID outbreak, and how the Singapore government looked at safety first, and then also realizing, knowing that economy is also important. So thank you for that. All right, next. We are also privileged to have our next speaker, Mr. Chuah, who is the former Director General of Health and Chief Executive of the New Zealand Ministry of Health. You can't get higher than that at the executive leadership in New Zealand's Ministry of Health, just to let you know. Chuah is a chartered accountant by training and has held C-suite positions in several public health systems called district health boards in New Zealand. And he has over 30 years of operational, strategic, and policy experience in healthcare services and systems. He currently speaks, writes, and provides advice on the future of health systems, leadership development, and caring for the older population. Mr. Chuah, please tell us about the New Zealand experience.
Hi, Alice, can you hear me? Right. Hey, first of all, thanks to the organizers for inviting me. I was really excited to be joining this panel because there's always lots to learn from other jurisdictions. I'm just going to pull up my screen and share with everybody. Can everybody see that?
Yes.
Okay. I'll just put it on. Okay. So I'm going to start off by just giving you, I've got just a couple of slides just to help me to talk. So this is the New Zealand context. We are quite a large country and we can fit Singapore in 369 times. And we are just slightly smaller than Vietnam. And you can see that we have a very small population, roughly around 5 million. And we have really only one major city, which is Auckland, which is about 1 million people. Our nearest neighbor is Australia. It's about roughly 2,000 kilometers away. And it's about a 3-hour flight for any of the major city except Perth, which is about 6 hours flight. If you, in the context of COVID-19, if you look at the number of visitors we get a year, New Zealand gets about 3.9 million. I think it's about 19 million in Singapore, about 18 million for Vietnam. And when you look at our health system, it's basically publicly funded through taxation, and we have universal health coverage. So that's kind of the context. This is the timeline for COVID in New Zealand. So our first case was actually 28th of February, 11th of March, WHO declared a global pandemic. On the 19th of March, our borders closed and a 4-level national alert system was introduced. And the country moved immediately into level 2. Within days, it moved through to level 3 and 4. And level 4 is the one, the most severe lockdown. And basically, no one's allowed out except to buy food. And when we talk about food, it is really only the supermarket because none of the restaurants, cafes, food outlets are really open. So the really funny side of that particular story was a couple of days before level 4 was introduced, all the students and all the young professionals made a big rush to go and buy pots and pans because you cannot actually order Uber Eats. Our first death was on 29th of March, and the country basically was on a standstill with no one moving a lot until about 27th April, where the alert level went down to 3. There's not a lot of difference between 4 and 3. In 3, I think takeaways were allowed, and that was pretty much it. On 13th of May, the level 2 is substantially different. A lot more activity was allowed. But on the 8th of June, the whole country went to level 1. Now, level 1 is New Zealand, is kind of where we are today. It is like pre-COVID. You can pretty much do anything that we did before COVID. Now, the interesting thing is between 8th of June and the 12th of August, it was around that time I actually returned back to New Zealand. And I stepped out of my quarantine on the 3rd of August and was absolutely shocked to see that in New Zealand, the people were walking around with no mask, no social distancing. There was no, very reduced level testing. So it was a very unreal environment. Well, that didn't last because on the 12th of August, we had a fresh community outbreak in the country in Auckland. And Auckland, the government decided to do a regional lockdown, and it moved the Auckland city boundaries to level 3. The rest of New Zealand went to level 2. And Auckland basically stayed under lockdown until 23rd of September, when they dropped it down to level 2 and the rest of us to level 1. And it wasn't until the 7th of October that we are now back to level 1. And that's where we are today. If you were to look at the New Zealand COVID management, it's been broadly described as the elimination strategy. So, the key points of the strategy is we shut our borders, and basically from the 19th of March, no visitors are allowed, only essential workers and very small numbers are allowed in, and basically only residents and citizens are allowed to return to New Zealand. And the strategy also requires, as I said earlier, that we used national and regional lockdowns, and there are 4 levels of alerts. The interesting thing about New Zealand is that our testing is largely just based on the RT-PCR test. There is limited to no surveillance testing using serology or antibody testing at all. Contact tracing is largely manual. The government introduced a digital tracer app that has been up and down. And the government has to work very, very hard to remind citizens and residents to actually download the app and actually to scan the QR code every time they actually go into a particular premise or on the transport. We don't have a live implementation of a COVID card, which is Bluetooth enabled. There is a very small trial going on, and we're not quite sure whether we'll get there. Now, with face covering, this is one of the non-pharmaceutical intervention that perhaps is a bit disappointing for New Zealand, and initially for a very long time, it wasn't actually part of our strategy. It was until really the Auckland cluster outbreak that the health and the politicians decided that we should actually follow the science of face covering. And actually, if you face covering, we're not talking just about masks. People use scarf, anything you just cover your face. So it's kind of a DIY approach to face covering. Now, this is the last bullet point. It's kind of the main, if you like, the main effective measure that they keep New Zealand safe. And that's, we moved initially from a home isolation and quarantine. And very quickly, the government realized that wasn't working. And then it basically switched that to a government managed isolation quarantine facilities. And basically, if you enter the facilities, as I did in the middle of July, you're basically there for 14 days. You're tested on day 3, you're tested on day 12, and provided both are negative, you're allowed out on day 14. The government introduced a user pay of New Zealand 3,000 per individual, I think sometime in October. There are 32 hotels that are operational in 5 cities, and it has a capacity of 6,300. Now, that capacity is interesting because today, if you are a resident or a citizen or even an essential worker, if you have to fly in, you have to book one of those 6,300 places. If you don't book that place, even if you can get an air ticket to come to New Zealand, you won't be allowed entry. The numbers of cases on 17th of November, it's a couple of days old. We have a total of 2,000 cases. Recovered is 1,919. We have 25 people that died. 16 of those were actually from 2 rest homes. And on 17, we have 61 active cases. If you turn to the broader health and social economic impact, virtually all other health services was deprioritized. So now the health system is trying to do a huge catch up, and that will be remains to be seen whether it will be successful to doing that. We have rising unemployment and business closures. The country is officially in recession. For the March quarter, the GDP was minus 1.4. For the June quarter, it was minus 12.2%. The New Zealand government has put aside $50 billion for a COVID fund. And we are funding that largely by increased borrowings. And you can see that as a percentage of GDP from the month of February to the April, in just that 2 months period, the borrowings moved percentage of borrowing from 19% to 25%. Out in the community, we are getting reports of surges in family violence, increased level of anxiety and other psychological distress, huge social disconnection, largely because of people working from home. We are getting quite tragic stories about elderly in care homes. Although only 16 have died, like most places, family members have not been able to see the elderly until quite recently for at least 3 months. And there are lots of tragic stories about elderly people dying, families not being able to actually attend the funerals and so forth. So there are broad health and social economic impact of the New Zealand response. And if I were to look at this is my last slide, response moving to recovery in 2021 and beyond, our borders are unlikely to be substantially open in 2021. There was discussions about trying to open the corridor with Australia, but given the situation in Victoria, which is now under control, but now with the South Australia outbreak, our Prime Minister basically ruled out any opening of the border with bubble with Australia for 2020. And from a personal perspective, I have grandchildren in Melbourne. I don't expect to see them until towards perhaps the end of 2021. One thing is very clear, our current response strategy is not sustainable going forward. We need a recovery strategy. And right now, the recovery strategy is basically anchored on huge government funding support. It's basically funded by increased borrowings. It's projected that our government borrowing will rise from 9% GDP to well above 50% in the next 2 to 3 years. The government's trying to keep the economy going by injecting huge, big infrastructure projects. So there is a lot of discussion around whether those infrastructure projects are they transformational, will it be a green recovery, or are we tinkering around with zombie industries? So from my perspective, I think that we will have a more difficult 2021 compared to 2020. And even with the recent optimism of vaccine efficacy, I think that we are likely to see more pain with regards to the broader health, social, economic impact. So if we were to now turn to looking at what were the factors underlying the successful response, if you like. Well, first of all, there's the New Zealand geography, and then there's the density of our population. Our political system is a single tier. It's had an enduring democratic process, and like Singapore, I think people have high trust of our government, and we, at this point in time, have a very popular Prime Minister. The role of the media cannot be ruled out because we have quite a small portfolio of media channels, and they are largely quite compliant. And there's not a lot of fake news out there. Our social capital is very, very high. So people are very happy to follow the government's regulations. And we do not underestimate the clear communication by the Prime Minister in the early days and the current Director General. And the point around leadership, both at the political level, at the health level, academia, and the private sector, is all part of the contributing factors for our successful response. Our infrastructure also is a factor because we don't have high-rise, dense population community housing, And New Zealand doesn't have any high-speed rail or public transport to talk about, so we don't have that risk. And last but not least, I think is luck. So I put down the Ruby Princess as an example, because the Ruby Princess, on the 18th of March, when they disembarked passengers in Sydney, that was one of the largest reasons for community clusters. That particular ship was in Wellington and Napier 3 days earlier. So if they'd been in New Zealand 3 days later, we would have a massive problem on hands. So I'll finish my presentation. I'll hand it back to you, Alice.
Thank you very much, Mr. Chai. It seems like, the government leadership is adapt to crisis and change management, right? Based on your success, it's about leadership, decisions, and that communication factor. So thank you very much for sharing that. Next, lastly, we have Professor Sarah Bales, adjunct professor at Hanoi University of Public Health. She is an American who has been living in Vietnam for the past 28 years. And she has a connection to Berkeley with an all but dissertation status in her PhD in economics. And she completed her PhD here in Singapore at the National University of Singapore's Lee Kuan Yew School of Public Policy. Now, Sarah has consulted with the Vietnamese government jointly through government institutions such as global institutions such as World Bank, the Asian Development Bank, the WHO, and United Nations on health sector and poverty reductions. And her core focus is on health financing, provider payment reforms, establishing health facility master lists, and advocating for greater use of data, administrative data for policy making and health system monitoring. Professor Sarah, we look forward to understanding how Vietnam has one of the lowest total cases per million amongst these countries we're talking about today. It's at 13 per million. The platform's yours.
Okay, thank you. Thank you for inviting me to join this panel. Let me share my screen and I'll talk you through what happened in Vietnam. Okay, can you see it? Okay, so Vietnam is a very clever country and they've been very successful at finding the right mix of things to do to try to control the coronavirus very quickly and effectively so that life can be returned to normal, which is what helps the government to feel that they have legitimacy and gets the support from the people, especially because the Communist Party Congress is coming up next year and that's a very important political event. And so there's a really big concern to ensure that what they've done is considered legitimate. So I think that's an underlying driver for the government's response. And maybe some of you have seen the famous video about washing your hands that the first page of the video on there. It's now in English and it's been used all over the world to convince people to follow basic public health hand washing procedure. So as both Jeremy and Chai had mentioned, that each of the countries has a sort of different geography and population that makes it more or less vulnerable. So Vietnam is very close to China and very close to Wuhan, and had workers in Wuhan who were returning from Wuhan during the Tet holiday, which makes it also very vulnerable very early on, before we knew very much about this pandemic. It has long land borders. So unlike New Zealand, it's not an island. It's very easy for people to cross over from Cambodia, Laos, or China to get into Vietnam. So it's not as easy for Vietnam to sort of control whether people are coming in who may be infected. It's a lower middle income country, so it doesn't have the kind of resources that Singapore or New Zealand has. It also has what's considered as underpaid preventive medicine workforce. So the emphasis in the health system has been very much on curative care in hospitals. A lot of resources are going into those areas. And it's considered that preventive is not the field you want to go into. You don't want to be in public health because you can't get paid as much. And so it's not as desirable as being a surgeon and very few people are really interested in working in that sector. Corruption is prevalent in the country. So this issue of trust in the government is really important. And there are a lot of trust issues in Vietnam right now. So that was a big challenge for Vietnam moving into this pandemic. Vietnam has high population density, even though probably not as high as Singapore, but the population is concentrated in lowland areas, in delta areas, because there are a lot of mountainous areas where it's very difficult for people to settle. There are major cities, Hanoi, Ho Chi Minh, Da Nang, Hai Phong, Cần Thơ, so they're sort of spread out urban area, not like in New Zealand where everything is very concentrated on a couple major cities. And Vietnam also, like Singapore, was hard hit by SARS in 2003, and then very soon after with the avian influenza. And so it's a country that has faced pandemic disease. It has had a history of that. And so in a way, it's a country that's in a region that's very vulnerable to that, because people live in very close proximity with wildlife and they are exploiting wildlife for food. And so there's a high risk. But at the same time, although it's a vulnerability of the country, it's also a strength, because very early on, they knew they had to have capacity, they had to be prepared. And even from the late 1990s, the US CDC was working in Vietnam, helping them to prepare their public health and their pandemic preparedness. So they've had a lot of assistance over the past years to help with preparation. So I think that was one of the factors that may have helped Vietnam to respond so effectively. So let me share with you now what the pandemic looked like in Vietnam. So first, look at the left axis and look at the yellow. These are the daily cases. And when I show this to people from the US, they're saying, are you sure you didn't make a mistake in the units? Should that be thousands or something? And no, the maximum number of cases in any day was 82 cases. And more recently, we have a few cases coming in from overseas. So we'll have maybe 1 to 12 cases per day coming in, imported cases of Vietnamese returning or foreign experts coming into the country who are tested and quarantined at the border. So you can see Vietnam has gone through a very early phase. We had 16 cases very early on, starting January 23rd. These were people returning from Wuhan or visiting from Wuhan. And then we were able to control that. So there were no cases, no community spread cases for 23 days. Then starting around the 7th of March, there was a young woman, a Vietnamese woman returning from traveling to Italy, and she brought coronavirus back. And then other flights coming in when they were not so strict on the quarantine for incoming flights. And we had another outbreak that lasted from March until mid-April. And that, it scared the government, and they started putting in place very, very restrictive policies to try to control that. So they gradually moved to where anybody coming in was quarantined. The quarantine was centralized rather than at people's homes. And so there were a lot of control policies. So then by mid-April, there were no new cases in the community, and the government decided, okay, we can loosen up. And so they loosened up, and we had a whole 99 days, like really 3 months of normal life, where gradually they were not reminding us about wearing masks. They were not reminding us to be careful. And we were getting, every time we make a phone call, there would be a reminder, make sure you're wearing a mask, make sure you're taking precautions. But that stopped, and life really returned to normal. People were going out to cafes, everybody was going back to work. And then in July, we had another case. It was a surprise in Da Nang and very unexpected, because we couldn't find the index case. We didn't know how this person got infected, but it led to a large number of cases and the first deaths. So the first deaths happened in end of July, and the epicenter of that outbreak was in the kidney failure and cancer treatment departments of hospitals in Da Nang. And so these cases were already very, very weak and very much on the verge of death, and they couldn't survive coronavirus. We had 35 total deaths in the country so far. But the government was very quick to respond, immediately locked down Da Nang. They put people into quarantine. They did massive testing and contact tracing. And so by the end of August into September, they were already back to no community cases. And of course, we continue to have cases because we have people coming into the country from overseas who are positive. But within the countries, now we're going on 78 days of no new cases in the community. So I think it's very clear. You can see the waves. It's very tightly controlled. And the other is that information was so transparent. These are information that are coming from Ministry of Health. It's widely available. Anybody can access this information. So I think that's also something that the other Jeremy and Ty have also mentioned about how important that transparency about information has been. This is just a quick one to show you the fundamental public health measures. I mean, this is basically, you've got a pandemic, you've got to put people in quarantine, you've got to do contact tracing, you have to test and detect cases and then find out who they're in contact with. Basic, fundamental public health. And this is something that the country, even though the health workers in preventive medicine were not well paid and it was a neglected area, when the pandemic came into Vietnam, the government allocated more resources. They were able to take their discretionary funds at the central level and allocate them for these purposes. And so I think even though it was neglected for the routine preventive medicine, when the pandemic came about, they had the flexibility to be able to take those resources from the central budget and use them to put people into mandatory government quarantine, not home quarantine. And you can see that the quarantine really reflects when the new outbreak happened in Da Nang, then you had a lot of people put into quarantine. And then as soon as the community spread had stopped, then it's only cases were flying in. They were not quarantining people based on symptoms, they were quarantining people based on exposure. So they have this F0 means the index case, and anybody who's F1 was put in hospital. So anyone who's direct contact with the index case is put in hospital and tested and followed for 14 days in hospital. The F2s and F3s, which are the F2s are first direct contact with F1s and F3 direct contact with F2s, were put into government quarantine. And then F4s and F5s were allowed to monitor their situation at home. Their temperature was taken every day. The local officials were coming and checking on them. And they were informed if any of their F3 or F2 contracts had become positive. So really it was a very effective policy. And because at the beginning, tests were not widely available. I mean, there just weren't enough test kits available. So they had to be very targeted in using the test kits. And so far, like the number of test kits used in Vietnam is not that many, but they were used very effectively. Vietnam's pragmatic response, and it was extensive preparation. I mean, they had experience from SARS and from avian influenza. They had close policy coordination. The Prime Minister and Deputy Prime Minister were very heavily involved on a day-to-day basis, ensuring that Ministry of Defense, Ministry of Tourism, all the different ministries were working together with the Ministry of Health to control the epidemic and control the harm to the economy as well. And then adaptation to new knowledge and dynamics of the pandemic. These are just two that I found that were in English that sort of show to people what the different measures that were being put in place to protect the population from the pandemic. So these are part of the response. And then I also want, this is my last slide. So the Vietnam's response, a lot of people are saying, well, Vietnam's a communist country, it's a communist state, they have a command and control governance. Of course, they can control the pandemic and other countries can't. But that's too simplistic. Vietnam is not a country that everybody believes in the Communist Party and thinks that it's going to save them and that they just follow a party line. There are a lot of people who are protesting and angry with the government. But Vietnam's government was very good at communicating to people that this is a dangerous situation. What happens, what are the consequences if you don't act? And so the communication measures, like this picture in the middle is a picture of a woman wearing a mask, and it's saying, it's a government campaign, Ministry of Health campaign saying, you're still pretty, you're still beautiful when you wear a mask. So there were, communication trying to get the society to have a solidarity, to protect each other, not just protect yourself, and create cooperation and solidarity. And the other, the yellow one, is saying, staying at home is being patriotic. So this is like, try to stay home so that you can help your country. So using a bit of the symbolism of the war, but it was quite effective. So I think, and then the small on the left is just to show that there wasn't government control. I mean, lockdowns were serious, quarantine is serious. These are like strongly implemented. They're not done like in a lax manner. They were very serious. But there was also like this mix of communicating to the local people and making sure that they believed and they were persuaded that they had to follow these measures. So mask wearing is basic. Everybody does that. It's normal. It's expected. It makes sense. And so people follow it. So I'm going to stop there. and then wait for the questions.
Thank you, Professor Sarah Bales. So this is great. I mean, we've seen the three speakers today talk about their respective countries, and it went from everything starts with a national response at a government level to population compliance, right? And of course, every country has the same toolkit, right? I think even the WHO has means of how to reduce the, to get the virus contained and for mitigation. But we also see that leadership, quick decision makings and timings and intensities of the measures are extremely important as well. Thank you very much. So for the last 10 minutes or so, we're going to go into the Q&A session. And I'm going to kick this off with a topic that is of great research to the School of Public Health. And I'm just going to I just want to share my screen just to give the audience some context. So this is an article, excuse me, this is an article from the Journal of the American Medical Association. And this one compares the characteristics between the influenza virus and the SARS coronavirus 2. And what caught my eye here is if you look at risk factors for severe disease is structural racism. All right, and now we know that structural racism is also a risk factor for the likelihood of infections. So I just want to inform the audience that what we mean about structural racism has nothing to do with biological differences, okay, or about the interpersonal relationships based on race, but it involves a macro level societal, institutional ideologies and discriminatory policies that lead to inequities in resources among racial and ethnic groups. And in fact, this is a fundamental determinant of health for worse health outcomes for Black and minority groups in the United States. And this pandemic just blatantly exposed the situation. So what I wanted to ask the panelists is, based on the demographics in your respective countries, have you observed similar observations as what has occurred in the US?
Maybe let me start the ball rolling. And I would say that the migrant worker population has been invisible and deliberately kept segregated for the longest time. There are no segregation policies per se, but the fact that the average migrant worker earns $400 to $500 a month means that there are many places in Singapore they just cannot afford to go to, right? And hence they tend to aggregate into specific areas, Little India and other ethnic really enclaves. And so they are a separate population, right? And I think that one of the silver linings around COVID is that it has shone a light and really galvanized a lot of public support to do things better. In fact, I'm involved in one of the migrant worker charities, and during the 2 months of the lockdown, our own donations spiked like 1,000% over that period. And typically we work with about 100 volunteers. During that time, we had almost 1,000 volunteers of individuals who could speak Bengali, Tamil, and so on, who wanted to come in to help us. So I'm quietly hopeful that in the aftermath, we can build a slightly more equal, or at least a less unequal Singapore. And back to you, Alice.
Thank you. Thanks, Prof. Derby. How about in New Zealand, Mr. Chai? Do you see this? Have you seen this in the populations that were infected?
Yeah, so if you look at New Zealand's population, roughly over 35% are non-European. Okay, so and when you look at that population, I think one of the big challenges in terms of our response has been getting the message out to the non-English first language speakers. Right? So I think that it is a particular issue, and I think that it will be a much bigger issue in the next phase as we look at the vaccination program. I'll just give a simple example. I think that, a common criteria that no doubt most countries will use will be, we will prioritize the elderly population. And most of the cutoff point starts around 65. The reality for many of our Maori and Pacific population, their elderly don't get to 65. So if we are serious about protecting those communities, then we cannot apply a universal policy perspective of protecting the elderly starts at 65. So we actually need to look at much lower level of age to look at vaccination for the Maori Pacific population. And it's just a simple, tangible thing. Like when I was coming back, going to quarantine, I saw a Middle Eastern older lady coming off the plane onto the same bus going on, and she speaks no English. And I'm wondering, okay, how is she going to survive through the 14 days of quarantine? So one of the interesting things, which is nice to hear and know, is I asked the nurses in the next couple of days and how the lady was going, and actually they said they actually did provide an Arabic speaking translator for her every day. So from that point of view, I'm quite, so New Zealand is perhaps is doing slightly better in sort of recognizing, we need to actually tailor it for different community.
Thank you. Prof. Sarah, does it apply to Vietnam?
In Vietnam, I think one of the issues about the demographics of the epidemic was a lot of the cases were people flying in, so they were people. Although some of the migrant workers, I mean, the government was bringing back migrant workers from other countries, and some of them were infected. And all of the services for citizens were paid by the government, so there was no financial barrier for people to get services, treatment, or even testing. So I think that was good. And during the lockdowns, there were what they call rice ATMs. So poor people could go. You didn't have to prove you were poor. You would go there, you would social distance, you would wait in line, and then you could get access to rice for free. That was donated by different companies to help poor people in the cities who didn't have those resources. But the epidemic didn't really reach out to rural areas. In rural areas, they were able to continue to work and feed themselves. So I think that kind of issue is not as important in Vietnam as it was in these other countries.
Okay, thank you. Okay, we had one participant who emailed their question beforehand, and this is from Alok Mishra, who is a cow parent. So he asks, what will it take for the countries who have managed well thus far stay safe in the short, medium, and long term?
Luck. Okay, a lot of luck. But fortune favors those who are prepared, and I would say that that we have to keep public trust and really confidence, because this is going to be a really long haul. The government has thrown in a lot of money to support industries that have been very, very badly hit. There are very active efforts to pivot the companies in these industries into other areas that are in growth, digital, things like e-commerce and logistics and so on. And I guess we can maintain solidarity and do a better job if the country as a whole is helping each other out. We are ramping up our healthcare facilities dramatically, testing facilities, and essentially we just have to prepare as best we can and hope that we detect early. But I think COVID has demonstrated, and if you look at the experience of Vietnam and New Zealand as well as Singapore, vigilance and early decisive action make a real difference.
Thank you. Thank you, Prof. Jeremy. I'm considering the time. We have 4 minutes left, and I do want to get to this panelist, this question in the Q&A for every panelist to answer. So Vicky asks, what do you believe are the most important factors or strategies in building public trust? That's a good question. Mr. Chai, shall we start with you?
Yeah, So I think the solution to the question, the most important factor is to build public trust.
Yes.
Yeah, I think transparency. Transparency, it's a fundamental layer. I think the next important thing is good and consistent communication, even when there is not a lot of new things to tell.
Thank you. Thank you. Prof. Sarah, what do you think?
Yes, I fully agree with Professor Chai that transparency, I think, was transparency that this is serious, that there are cases in your community, that we actually even knew which district people were living in, where there were cases. So that helped people to be aware that this is dangerous. We need to take precaution, we need to protect ourselves, and we need to protect our community. So I think that was really crucial. I think the other thing that was important was that the policies made sense. They weren't too draconian. There was not, like during Vietnam's lockdown, people could still go to work. They just had to be careful at work. And you could go to the grocery store. You couldn't go out to a restaurant. You couldn't go out to a bar. You couldn't go out to a movie theater. But you could still work. You could still earn a living. Online shopping thrived during this time. People could still buy the things they wanted. They could still buy clothes because you could buy them online. So I think that the balance and that reasonableness in the pragmatism, that was really helpful to make sure people could persist. And the other was the quick response, getting rid of all the community cases so that life returned to normal as quickly as possible. People said, wow, our country's doing great. We look at the US and we're like, we're so happy to live in Vietnam. So I think there were a lot of those factors that helped.
Thank you.
I would just
Prof.
add, I would add two very quick points. One, you don't build trust only when you're faced with a crisis. Trust is built 2-3 decades before that, through all the factors that Chai and really Sarah had eloquently described. The other thing that I would add is really this sense of really authenticity and the very clear sentiment that we're all in this together. And if it's seen as some are suffering and some are not, then things fall apart very, very quickly.
Thank you. 2 more minutes. So Michael Bates has a question. What provisions are in place in the 3 countries for access to COVID vaccines when they become available?
Oh, I will take Singapore's strategy very, very quickly. Spend a lot of money, make friends with everyone, okay, and then basically prioritize healthcare professionals as well as those who are vulnerable. That's it.
Mr. Chai?
I think New Zealand is part of the COVAX arrangement. So the governments have announced that they have purchased a list from 2 vaccine developers.
Thank you. Prof. Sarah?
Has 4 different companies that are working on trials of vaccines. So biotech was also strongly involved in the response to COVID. So they have 4 companies that are involved. They're not able to do trials in Vietnam because we don't have any cases. So they're connected with universities in UK and in other places that are doing reliable trials. The other is that they've also ordered some vaccines from Russia. That's a Sputnik vaccine. But, they're also probably working with the Chinese to get the Chinese vaccine. So I think they're sort of risk averse, and they're trying to make sure that they've got everything covered to get vaccines when they're available. And also, of course, they work closely with WHO.
Thank you. All right, right on time. On behalf of the PHAA board, we are thrilled about today's webinar. We thank you so much. And we do have a small token appreciation that will be sent to you through the email. So please look out for that email. But thank you very much.
Thank you, Alice.
Thank you, everyone.
Thank you.
Hey.
Have
Bye,
a good day.
Jeremy. Bye,
Bye.
Sarah.
Stay safe. Yeah.